Good morning, everyone. Thank you, chairpersons and Dr. Singh and Dr. Paragrana and team for inviting me for this talk. With the advent of imaging of coronaries with the help of optical coherence tomography, now we have started understanding atherosclerosis in a much better way. We now know what intimal fibrosis looks like apart from histopathology textbooks that we see. We now know what the vulnerable plaque looks like when you have a thin cap fibroatheroma or a thin cap fibroatheroma. You can see that this is all covered with bright tissue, which is thick cap fibroatheroma, and here there is hardly any thick tissue, meaning thereby it is a thin cap fibroatheroma. So now it is possible to identify vulnerable plaques from the coronaries within. And that's how we see about the vulnerability of the plaques. You can see thin cap fibroatheromas, lipid-rich plaques. You can see microchannels, which indicate that the plaque has got vascularity. You can see macrophages actually, and even cholesterol crystals, a bright spot like this, and spotty calcium, which are all indicative of future event rates as far as cardiac events are concerned. So now, since the science has progressed so much, we need to identify what are the surrogate predictors or clinical markers of aggressive atherosclerosis. So I think this table summarizes all those factors. We all know everything about these factors: age, diabetes, hypertension, CKD, among all this. And apart from persistently elevated LDL cholesterol levels higher than 100 despite maximally tolerated statin therapy and ezetimibe, this also indicates a very high risk feature for future ASCVD events. And then there are certain ASCVD risk enhancers. I would like to draw attention to ethnicity, South Asian ancestry. It indicates enhanced risk to ASCVD events. And secondly, elevated LPA levels. So these factors here in selected individuals, LPA levels higher than 50 milligram per deciliter indicates enhanced risk of ASCVD events. So these are the factors which we need to consider as far as risk prediction in a given individual is concerned. So I'll just give you an example. How would you treat this patient for a secondary prevention? This is a typical report that you will get from Toprani lab, let's say. You have LDL cholesterol of 106, you have triglyceride of 132, you have non-HDL of 129, and total cholesterol of 171. So typically, if it is for a secondary prevention, one would feel that levels of cholesterol we should treat with a statin, 50% reduction, or levels less than 70 milligram per deciliter we should be achieving in this given patient. But suppose this patient is for primary prevention, then what would you do? Let us say this is a report of entirely healthy individual who comes up at the age of 20 with this report. What would you do? Maybe lifestyle modification, that's all. Because there is no point in giving drugs to him, right? And there are no other factors except for South Asian ancestry probably. So I will draw attention to this particular article. Normal LDL levels are associated with subclinical atherosclerosis even in absence of risk factors, published way back in 2017. And right from 50 to 60 milligram per deciliter, there is a linear evidence of atherosclerosis developing in several vascular trees. And as the levels rise, atherosclerosis increases. So are we justified in sticking to one level? The risk is continuous, linear, and rises. If the same patient now comes up with this level of lipoprotein small a 20-year-old, healthy, young, without any risk factors, has lipoprotein A levels of 84.8, which is well above your cutoff point, normal value being less than 30, and any value higher than 50 is considered very high risk feature for thrombotic events and vascular events in future. If this same individual comes up with this, what would you advise to that 20-year-old? Would you start medicine? Where are we? Right? So we have to understand that lipoprotein small a is also markedly more atherogenic than LDL, and it increases the risk of events by almost 6 times, even with a normal LDL cholesterol levels. So these values cannot be really taken with lightly, right? Suppose you have achieved in a given patient LDL cholesterol levels of 70. Are we achieving good protection? So there is this article, the residual inflammatory risk in patients with low LDL cholesterol levels undergoing PCI. What it says, all those patients who have undergone PCI, they are put on statin and they have achieved levels of less than 70. What is the risk? What they have found out is that many patients continue to have high CRP even post PCI, which is a surrogate marker of inflammation. And all those patients at 2 time points, if they show persistently elevated levels, they tend to have higher risk of events in first year. Meaning thereby achieving LDL cholesterol target alone is not enough. And probably achieving target of 70 alone also does not give you that degree of protection unless the inflammatory markers are showing trend of subsidence after the acute coronary syndrome and after PCI. And therefore, these are emerging concepts that we need to identify. One is progression of atherosclerosis is linear with LDL cholesterol levels. Burden of atherosclerosis parallels lifetime exposure of LDL-C levels. So let us say your levels are today 110 and without treatment you are just monitoring and levels of cholesterol after 3 years, they are 120. After 5 years, it is 130. Probably you are also having parallelly progression of atherosclerosis as far as vascular is concerned. And therefore, target LDL-C reduction will need to be titrated individually for every patient. And cutoff of 70 does not always translate into reduction into MACE. And South Asian ancestry with elevated LPA levels will add to complexity in management. Here comes the concept of LDL-C variability. We are all aware about diurnal variations. Diurnal variations are all physiological, right? Variation in heart rate, we are considered physiological, right? And rather non-variation of heart rate is pathological. If heart rate does not vary, we consider it pathological. But for blood pressure, we don't say that. Variation in blood pressure in the background of good BP control is called pathological. Even though a person has a good BP control, if it fluctuates more, it is also associated with risks of stroke and acute coronary syndrome. So meaning thereby variability for different physiological parameters is also to be considered in a given perspective. It can be pathological, it can be physiological. And therefore this concept of LDL variability was floated in last decade, and there are now several studies how LDL variability over time is important. So it has been shown that LDL-C variability is an independent predictor of cardiovascular events. Here we can see the graph right from 20 years to more than 60 years. Effect of cumulative exposure to LDL-C on plaque burden and risk of cardiovascular disease. It tends to increase over time as the age advances. This is one small trial published in 2015 by Sripal Bangalore in Journal of American College of Cardiology, which says that visit-to-visit LDL variability is associated with adverse clinical outcomes. What they showed was that visit-to-visit LDL variability is associated with 16% increase in MACE events, 11% increase in any cardiovascular event, 23% rise in death, 10% rise in myocardial infarction, 17% rise in stroke. So even though your cholesterol level may be falling into reasonably normal range, let us say between 70 and 100, fluctuations are associated with plaque progression within. And at times, higher the plaque progression, higher the inflammatory milieu, adds to the component of possibility of plaque rupture. And therefore, it is important that those patients who are on statin need to have consistently low variability or non-variability of LDL levels. So, given this kind of scenario, let us say how many patients with established cardiovascular disease are on high-dose statin for long term? Typically, no. Let me tell you my own experience. For so many years, we have reduced down statin once the patient achieves target, forgetting that probably this level will be now remain static in a given dose of statin. If you see the same patient after 3 months, 6 months, 9 months, probably you will see that LDL-C has started again rising. And that patient, if he is lost to follow-up, comes after 2 years with MACE, probably it is, as a medical professional, we are at fault that probably we did not advise that you need to have consistently low levels and persistent suppression of LDL-C levels. Are there any individual predictors for LDL-C variability? Practically no. We don't know which patient will have that sustained control over given dose of statins, which patient will not have it. We don't have clinical predictors. Now we know that extent of LDL-C variation with statin versus PCSK9 inhibitors, if you see, statins typically reduce LDL levels by 20 to 24%. Monoclonal antibodies along with statin reduce close to 40 to 50%. Inclisiran alone, now with a newer drug, it tends to establish reduction in LDL-C reduction by almost 45 to 50%. So significant reduction in LDL-C levels are achievable with newer drugs like PCSK9 inhibitor Inclisiran. What is important is now with this kind of concept emerging, I believe that most patients will require moderate to high dose statin for long term. All those 10 milligram and 5 milligram of statins will go out of picture, and that should be rather discarded as far as our clinical picture is concerned, looking into high-risk population that we are encountering as far as Indian subcontinent is concerned. Most patients will require high-dose statin to be continued for long term, and therefore there are going to be issues with compliance and cost effectiveness. How many will continue high dose for a long term? Side effects, some or the other, are going to be there. Of course, we know that low dose are not associated with side effects, but if you, let's say, 40 milligram of rosuvastatin for long term, you will encounter some or the other side effects. And at least we could say that at least 4 to 5% of patients, they want that, no, this drug should be off. I am not happy with this high dose, right? So this is a reality, that now is the time where you will need high dose statin to be continued for long term, and you are going to encounter problems with compliance and side effects both. And of course, the extent of risk reduction that now we want. With degree of LDL-C reduction which is achievable with statin is, let us say, 20% versus Inclisiran going 50%. Definitely, the more the extent of reduction, more is going to be the protection. So Inclisiran group may be giving, let's say this is projected 50-year therapeutic window of 52% relative risk reduction compared to statin, which is going to give you close to 31% relative risk reduction. And therefore, when we see that ESC guidelines in 2023 for ACS management, what they recommend is LDL-C reduction of less than 55 milligram per deciliter. We can see that how the projected reduction in the LDL-C target, the progressivity is coming down from 100 to 70, and now ESC recommends less than 55, right? There is this huge unmet need of LDL-C goal achievement among Indian patients. This is a study published in the International Journal of Cardiology, Indian data, and more than 500 patients studied over a period of 1 year after ACS event. And what it showed was that 79% of patients did not achieve target LDL-C level less than 55. Only 20% achieved it with current dose of moderate to high dose statin. And if you talk of 70 milligram per cutoff, 55% did not achieve. That means despite moderate to high dose statin therapy over 1 year post ACS, sizable number of people do not achieve target LDL levels, and translating into high risk of recurrent events, right? And therefore, we have to understand that we need to provide something which can have compliance, which can translate into effective reduction in LDL levels and reduce LDL variability as well, right? This is CSI 2023, Cardiological Society of India 2023 recommendations. And you can see what are these terms: low risk, high risk, very high risk, extremely high risk. Now, where are these predictors for us, right? For low risk, LDL-C level target is less than 100, LDL-C less than 70, very high risk less than 55, and extremely high risk, meaning thereby ASCVD with heterogeneous familial hypercholesterolemia and elevated LPA, your target LDL-C should be less than 40, right? So the example we discussed of a lipid profile, which has a LPA level of 88 with LDL cholesterol of 108, probably will fall here. For that person, LDL-C reduction should be from 108 to less than 40, right? You need a more aggressive approach. This is a recent article, expert consensus document, which is agreed upon by UK, NHS Pathway and ACC, which says that all patients for first 3 months should be on high dose statin. If required, add bempedoic acid, and after 3 months, if they are not achieving target levels, you must add either monoclonal antibodies or Inclisiran, and follow these patients closely over a period of 3 months, 6 months with follow-up lipid levels, and see are they achieving that level of risk reduction or not. Because unmonitored, they will present with acute coronary syndromes, right? And therefore, there is this space for new molecule which is now available to us, Inclisiran, which has potential to reduce LDL-C variability with convenience of dosing. So a word here that this reduction in LDL-C variability, is it unique to Inclisiran? No. High dose statin also can lead to reduction in LDL-C variability. So 80 milligram of atorvastatin or 40 milligram of rosuvastatin also will lead to reduction in LDL-C variability. Important is to have that high dose continued for a long time. And there the picture comes up where the role of monoclonal antibodies and Inclisiran comes up, because they are to be given less frequently the compliance improves, and therefore you are not worried about LDL-C variability coming into picture, which can precipitate into plaque progression and major adverse coronary events. And of course, there is this convenience of dosing also. Inclisiran has got a unique mechanism of action. At the end of the talk, maybe I will request the Novartis to play the video of mechanism of action. But typically with PCSK9 inhibitor, more and more LDL receptors, they are able to come to the hepatocyte surface, which clears the LDL cholesterol from the circulation. And that's how it reduces the levels. And there is a sustained almost 50.5% reduction in cholesterol levels, and of course the inter-individual variability as well. Patient-level pooled analysis from multiple trials, Orion 9, 10, 11, has shown consistently that 26% reduction in composite MACE events compared to placebo over 18 months. Numerically lower events of MI, numerically lower events of stroke as well. And we still need to understand that these data are still accumulating. This is still data in evolution. We have data for almost more than 8,000 patient years, maximum exposure of 6.8 years, and the drug is supposed to be very safe. Except for local injection site reactions, there are no major side effects, no major drug-drug interaction. It is safe in hepatic and renal impairments, and there are no off-target side effects. 2 doses a year, healthcare professional administered, single pre-filled syringe, no refrigeration required. So I think this is a drug which should be, which is likely to be used more frequently given the clinical scenario that we are facing. Typically, if we talk about lipoprotein small a levels, Inclisiran typically reduces LPA levels by 20%. There are certain drugs which are working on similar mechanism, and they are going to be available in a year or two. Data with pelacarsen is going to be available by next year. It is an antisense oligonucleotide which again targets the mRNA, which is transcribed from the LPA gene, and it can reduce LPA levels by more than 80%. Another drug, olpasiran, is again similar to Inclisiran, is again small interfering RNA which prevents translation of ApoA protein, and almost 100% reduction in circulating LPA levels. So I think these are the drugs which we will be looking forward to as far as our population is concerned with adverse lipids and high LPA levels. So I think with this, I'll end the talk here. We'll be open to questions, and I think we have 2 minutes more for understanding the mechanism of action. I think it is more, it's fantastic video to see, basically to understand how the drug acts. It is simple to understand how enzymatic inhibition will translate into reduction in cholesterol synthesis, but something what happens at the intracellular level, it would be exciting to see. I'll ask Novartis to play the video.
Excellent talk, Dr. Chirag sir. Oh, yes.
The
Just
liver
1 minute.
controls LDL-C levels in the circulation by regulating the synthesis of LDL-C and the clearance of LDL-C via LDL receptors. A target protein produced in the liver interferes with the clearance of LDL-C from the bloodstream by reducing the number of LDL receptors available to remove LDL-C from circulation. Cybrava, the first and only small interfering RNA therapy for LDL-C reduction, selectively targets the liver. After administration, Cybrava is selectively taken up by hepatocytes and is rapidly cleared from the bloodstream, reaching undetectable levels within 48 hours of administration. Stored within the endosome, Cybrava is slowly released into the cytoplasm, where it loads onto the RNA-induced silencing complex, or RISC. Once loaded, the complex consists of Cybrava and the body's naturally occurring RISC, sequentially cleaves multiple copies of the target protein mRNA, continuously preventing its production. This increases the number of LDL receptors on the surface of the hepatocyte, which results in greater hepatic uptake of circulating LDL-C. As a result, Cybrava allows for effective and sustained reduction of LDL-C in the bloodstream.
So I think, thank you for your patient hearing. I'm open to questions.